We're talking with Dr. Greg Phelps, Medical Director of Hospice at UT Hospital in Knoxville. Greg, welcome to the Dr. Bob Show.
Thank you very much. Thank you for having me.
Well, first of all, tell me exactly what is hospice?
Well, I guess the best answer I can give you is hospice comes from the same word that means hospitality, and it is care for those people in their final months or weeks of life. It is a focus on more on their comfort when a cure can no longer be achieved. So we're focusing on trying to make them as comfortable as possible. People think sometimes about hospice as end of life, but it's really having the best quality of life you can for as long as you've got left.
Is a key word to that, though, a time in life where there's anticipated there's not a cure? Is there a period of time that they anticipate death will occur?
Well, the regulations call for when a reasonable doctor would not be surprised, and we call it the surprise question, would not be surprised if a patient like this, if their disease followed the usual course, had 6 months or less to live.
So 6 months is sort of a key time area.
If that's what they think that's going to happen, but we have a certain percentage of our patients that live longer than 6 months.
When people go into hospice, it's usually, what's the length of time that they will stay there? It's just much shorter than 6 months, isn't it?
Well, it's usually much shorter. Unfortunately, it should be somewhere in the 100 to 120 days. Our average length of stay is in the 40-day range, and unfortunately, a third of our patients come in and are only with us less than 3 days.
So it's really, for those people, it's people that are really at the end of their life for sure, 2 or 3 days left to go.
Yeah, and that's unfortunate because that's difficult to do your job and get the patients to where, the goal here is for them to be able to talk to their family, reconcile, heal in the sense of coming to oneness with their family, and we're still trying to get their medical symptoms under control.
That's a beautiful statement. So with hospice, first of all, I've got a myriad of questions that I want to come down to sort of a summary, but what is available under hospice? Is it doctors, nurses, counselors,
yes.
religious care, all the above? So tell me what's available.
Well, hospices are unique in that what Medicare requires is that you have to have a program that has a doctor for medical director, nurses' aides, chaplains, social workers, speech therapists. We have to offer at least a small amount of physical therapy. And finally, we're required by law to have volunteers that can come into the patient's houses and help them with like housework and stuff like that. It's the only thing that Medicare requires that for.
So you can have hospice in the hospital, in the house, in a hospice agency. Tell me about, where do you house the patient with hospice?
The vast majority of our patients are housed at home. The goal is for them to stay home and be with their families, which is where the vast majority of people say they want to be. Unfortunately, only about a third of the patients who pass away are at home, which is where they want to be. There is a hospice inpatient unit that Tennova has in North Knoxville. Very occasionally, patients will be in what we call general inpatient in a hospital. And then, of course, there's the palliative care service that's in the hospital that does a lot of that work as well.
So most of the time it is at home. Now, you mentioned all these services. Are they required for every patient? Do you have to have social counsel, social worker, a priest or a preacher, a aide? Do you have
all
to
of
have
those,
that?
the patient is free to decline those services, but yeah, it's kind of like a train stop when the patient first comes in, because all those people have to come in and see the patient within 5 days. And so I tell patients, brace yourself, there's going to be a lot of people coming through for the next couple of days, and then things will calm down a little bit. We also provide medications related to the illness that comes for the patient. That's free to the patient, along with durable medical equipment.
Now, what's durable medical equipment? What does that mean?
Hospital beds, wheelchairs, walkers,
so those are available.
Oxygen, yes.
So you can get a hospital bed to make somebody more comfortable at home.
Yes.
Does the insurance usually cover most of that?
Hospice, at least for Medicare, is 100% covered. As long as they're in the home, everything, medications, the staff, the equipment are all 100% covered.
Well, that's wonderful for the patient.
Yeah.
So that would be a bed. You said some other things, but I cut you off. Would it be like a wheelchair?
Wheelchair, bedside commode, oxygen if they need it,
Wow.
whatever equipment they'll need to be at home.
Now, what about pain? How is pain managed at home? Let's say somebody has cancer of the lungs and it hurts.
Okay.
What's done for that person as far as making them comfortable at home?
We work really, really hard to make our patients comfortable. Our motto is whatever it takes, and so sometimes patients come into hospice and they're so grateful because their doctors have been afraid if they medicated them that something would happen. One of the things that we're uniquely qualified to do is treat pain very aggressively, and so we have everything from oral medications to pain pumps to you name it to try to get the patients comfortable. But there's a lot of fear about opioids, and all the conversation about pain clinics has made people paranoid.
Sure.
And most of those things, if done well and done right, patients can be made comfortable, or as we say, being human, suffering is part of the human condition, but pain is frequently optional.
Who sees the patient? Let's say that somebody's at home in their end of life. They've got a 6 months period where you anticipate they have a good chance of not living for that 6 months. They're declining. Who comes by? The family doctor, the medical director, a physician under hospice?
Well, the patient is referred usually by their doctor. It could be an oncologist, a cardiologist, their family doctor. And the family doctor or any of those doctors can continue to manage the patient, but a large percentage of them have me pick up as the hospice medical director. In terms of who comes and sees the patient, it's mostly the nurses and the nurses' aides and the chaplains and the social workers. It's kind of funny, my wife is a nurse, and I joke that I don't do the work, the nurses do all the work, and she likes that.
Well, that's the way it is at our office too.
Yeah.
The nurses do all the work, the doctors get all the credit.
There you go. I go see patients as I'm asked to. I've been married to a nurse for 35 years. I go where I'm told. But most of the work, the nurses come by at least once a week, as many times as 3 times a week. If they're needed to come more, they come more if there's a problem. But usually 1 to 3 times a week is what they do. The nurses' aides come as they are needed. Chaplains and social workers don't come quite as often as that, unless they're needed. They're our troubleshooters. They run out and fix things for us.
If somebody has diabetes, type 1 diabetes, and they're on insulin, and the family doesn't know how to give the insulin, does the nurse come by every day under hospice and do that?
They would teach them how to do it. We do lots and lots of teaching. I mean, when you come in, you get a book like that, just starting in, and that's just for the general hospice care.
Is it hard on the family, the person that's there, understanding the troop of people that's available to them, or it's a huge comfort to know that it's available?
It's a large comfort to patients to have all this support, and that's what we hear again and again from our patients or their families, is how much they appreciated all the support that they got. I've had more than one patient say, if this hadn't been the worst time in my life, this would have been the best time in my life.
It's a beautiful statement. Every time I hear the word hospice, I've never heard anybody that didn't say it was the most wonderful thing for their family, and they were so pleased that they had that available to them. Greg, before we go on, let's look at a patient that was involved with hospice and see how it helped their family. We're talking with Janae Sylvester. And Janae, welcome to the Dr. Bob Show.
Well, thank you very much for having me.
Your mother died 4 years ago. What
Yes,
was
sir.
the cause of her death?
She had lung cancer and it metastasized to her brain.
And you knew that her death was inevitable.
Yes, sir.
What did you do?
Well, the first thing I did was contact the primary care doctor, and she knew right away what I was there for, to get hospice involved, because I came down to take care of my mom and I wanted her to be comfortable.
How did you know about hospice?
I knew about it because of working as a nurse for as long as I have. I've worked with them in the hospital, nursing home, and at home situations too.
So your mother was in Florida. Did you want the hospice to be at home or in a hospice facility?
Now, I wanted it at home. I wanted her to have the dignity of being at home and being around her children. I think it was important to her that we were there.
What was hospice able to do for your mama?
Oh my gosh. I mean, I just took a telephone call and I had every single thing I needed. I got the bed, I got all the equipment, I got all the medication that I needed. They were just absolutely wonderful.
Did it help your mother?
Yes, it did help my mom. It helped her understand what was really happening to her and helped her come to the realization, yeah, I am going to pass away. And they really helped her understand that. It was awesome.
You know, it's such a sweet story. Death can be very private, and it can be very graceful, and it can be a really pleasant experience like
Yes.
that. Your recommendations for hospice?
Oh my gosh, anybody who really needs them, not to be afraid to call them, because they're there to help. I mean, that's one of the really wonderful things about them. They will do everything, and they've even followed up. They followed up 2 years later. They called me to find out how I'm doing.
Were you surprised at that?
I wasn't really totally surprised, but I was in the fact that I was grateful that they took it upon themselves to spend a little extra time after my mom had passed away to make that phone call to ask me how I was doing. It was awesome.
You know, Janae, listening to your story gives me the warmest feeling. It's a wonderful thing that hospice. Thank you so much for coming and sharing us the story of your mother and hospice and how it helped you, your mother, and the family.
It did. It was wonderful. Thank you so much.
Wasn't that a nice story about the involvement of hospice in the care of a patient? We're talking with Greg Phelps, board-certified medical director of hospice at UT Hospital in Knoxville, Tennessee. And Greg, tell me, what are the most common diagnoses that people have that go into hospice?
Well, probably the one that most people think of is cancer, and that's a very, very common one. Ones that people think of less are Alzheimer's disease at the very end stages, end-stage heart failure, kidney failure, liver failure. You're seeing a common thread here.
Lung failure, body failure.
Yes, and some of those patients we just have as adult failure to thrive, that they have to have a medical reason like dementia or something else to put them in. What we used to call the dwindles.
Yeah. When a patient is admitted into hospice, and they get hospice care at home, which is the most common place, it looks to me like a real involvement is making sure that the family is in sync with the patient in their directives. How's that handled?
Well, the first thing I would tell you and your listeners is that it is important to talk with your family about your end-of-life wishes. Make sure that they're known. You can get paperwork to do it very easily off the internet, but the family then talks with, and the patient talk with us. We have our chaplains and social workers to help them with that. Sometimes patients don't really know what they want to do.
Sure.
And so we say, paint us a picture of what your life would look like towards the end. How do you want to be seen? How do you want to be remembered? And use those values that come out of that conversation to come up with what their advanced directives would be.
Do you help people get involved in their funeral?
We do. We actually help them make funeral arrangements if we need to. We try to help them do memorials. Our staff will help them do scrapbooking, what we call a life review with the patient if that's something that they want to do, to help them find meaning in their life. There's one philosopher said, life is lived from front to back, but understood back to front.
You know, it's a beautiful story that you're presenting here with people that are at their end of life and making it more comfortable for them and their family. When the patient dies, what is available to the family after that? Is the story end right there?
No. We provide bereavement services to the family for 13 months afterwards, as does all hospices, and this is support for however the patient defines their family. In this day and age with all the different permutations, it could be, we've even provided family support to nursing homes where that patient lived and that was their family.
So bereavement can be just about anything. Are they helped predominantly with counseling then? With a counselor that you have, social counselor, priest?
We have a lady whose full-time job is to do counseling with patients. In really awkward or difficult situations, she'll even go out and talk with the patient and their family while the patient is still with us to try to build a relationship with them. We actually risk stratify our patients as to how badly we think the family is going to take it so that we can be prepared to respond appropriately.
I would think if there is an organization that's involved with end of life, that some of the fears would be, well, are you trying to speed up death? Are you trying to keep death from occurring? Are you just making it evolve at a more reasonable level for the family and the patient?
Well, we're trying to make the end of life as comfortable both for the patient and for the family as we can. At the same time, we neither hurry nor hinder death, but oddly enough, there's data over and over again in cancer and heart failure and other illnesses says if you're getting good care, somebody's coming into the home, helping you with your medicines, helping you with your care, those patients actually live longer in hospice. For patients with heart failure, it's 3 months longer. In patients with cancer, it's 3 months longer. If hospice was a drug, we could sell it.
That's wonderful. You know, there's nothing like the association with fellow human beings that are concerned about the care of somebody that's at the bedside. Who does most of that in the home at the bedside? Doctor, nurse, social worker?
Actually, it's the certified nursing assistant is probably the person who is closest to the patient.
What do they do?
They are the most intimate contact with the patient. They help bathe them, they help clothe them, they care for them in the home. They're only there for a couple hours here and there, but that when we have patients thank us in obituaries, it's most commonly the CNA is who they remember.
Are the family members allowed to come in how much and to care also?
Oh, well,
freelance?
The families are expected to provide the majority of care. We're there to help support the family emotionally, spiritually, physically, however we need to do that. As I mentioned, we even have volunteers that will come in and sometimes do shopping or sit with the patient. But the care for the patient is really a multitask from all these people coming in and helping.
When somebody has a terminal illness, end of life, where would a situation be where they would not want to use hospice? It would seem to me like they're still hoping for a cure, that they don't want the thoughts of end of life.
That's always a bit of a struggle because some people can't get into the idea that the end of life is coming. As I tell my medical students, life is a terminal illness. It's going to come for us all at some point. So it's a real struggle at times. Some patients struggle to the very end. They get chemotherapy, they get, what's the next treatment? I've had patients who've been to 4 and 5 doctors. We do provide what we call palliative care, which is when patients are still seeking curative care. It's what we would do in hospice, but on a very limited basis, looking mainly at keeping them comfortable.
So keeping them comfortable means toilet activities or pain management or breathing or yes?
Symptom management, whether it's pain, nausea, spiritual angst. The palliative care team is kind of like about a third of the hospice care team that comes out.
When you are near the end of life, is the family the most important thing to deal with, or is it the patient, or it's a combination of all? How do you allow somebody to die?
It's at its best, it's the family is there supporting the patient. I had one patient who said their family was there to pray the way for them. We all hope that we'll be with our family. I've never had a patient say, gee, I wish I'd spent more time at the office. When you get to where time is precious, that's family is what comes up over and over again is what they really want to spend their time with.
Anything that people need to know about as they plan for their end of life? Do you meet with somebody 20 years before, 5 years before, 2 years before, wait till you get sick? When do you begin to think hospice for your own self and your own family?
Well, I'll tell you, when I go out and talk with patients and talk about end-of-life care and advanced directives, we'll go through with the designated patient, we'll go through the paperwork, and then I'll hand out copies to the family and say, all of you need to do this. My advanced directive actually is in my car waiting for me to give it to Wes Dean, my family doctor. It's never too early to think about that and how you want your life to be remembered. One time I was teaching a high school Sunday school class, and I had them write their obituary and say, begin with the end in mind. How do you want to be remembered? So it is, there are programs at Thanksgiving, Talk Turkey, the National Advanced Directives Day is the day after Tax Day, it's April 16th. It is never too early to start talking about what you would want for when you're looking at the end of your life.
I've always thought about writing my own obituary. Is it better for the person to do that or for the family to do that after you've died? Mine, I would probably be too long.
Mine too, but I've kind of worried about that. I would like to have mine written the way I would want it done. So.
Yeah. Greg Phelps, wonderful discussion. It just warms my heart to know that people at such a time in their life that's so important, death, that there's somebody there to support them that's professionally trained to do that in taking all aspects of life. You've given a great presentation. I feel very comfortable about it.
Well, thank you. I hope I don't see you for a long time.
Yeah, I hope you don't see me for a long time. But thank you so much for coming to the Dr. Bob Show.
My pleasure. Thank you.